The framework of the randomized clinical trial, of course, to the physicians in the audience is the historical gold standard of proof of a therapeutic intervention in people and its effect as a measurable outcome. But as I think you've heard today, Dr. Lauer's question in particular touched on this notion of our studies being designed to address questions a priori, and are there other methods and models of doing these trial designs that may come up. But in the meantime, we have an incredibly rich environment of investigators who have engaged in a variety of different areas of clinical research, clinical trial research, and we picked 3 of them as representative and don't mean to cover the entire spectrum of work going on at Einstein and Montefiore. The first speaker is Mark Einstein. I gather he's no relationship to our eponymic medical school, though Mark and I go back a few years since he was one of our first K-12 awardees. Mark is now Associate Professor of Obstetrics, Gynecology, and Women's Health, and he'll be talking about his work, which spans the genomics and the therapeutics of HPV-related cervical cancer in women. Mark?
Thank you. Thanks, Dr. Shamoon. Can you guys hear me? Can you hear me okay? I'll just do the podium. I speak loud, and I'll answer your questions loudly, I promise. I want to thank the organizers of the meeting for inviting me to talk about what has been a very busy program in clinical and translational research, and that is particularly in cervical disease. And the reason it's busy is because we have really kind of like the 3-legged stool to be able to effectively do clinical and translational research in cervical disease. And we've, for decades, have had internationally renowned expertise in HPV and HPV-associated basic sciences with Robbie Burke and Howard Strickler and Gloria Ho and a number of others in the Department of Epi and a number of other departments. We also have, simple country doctors like myself who see the patients and have been very involved in a lot of these teams and interdisciplinary teams and really kind of honing in on some of the more salient and, the now kind of clinical questions that my clinical colleagues regularly have, and trying to bring that and trying to answer this in a translational fashion. But also, and I think that this, I see the topics that, and the other speakers, and I think they all agree with me that we also have the patients that suffer from this disease in our surrounding Bronx community, and ultimately it is our goal to kind of bring some of these translational questions that we have and bring it back to those patients in what I would think and I hope are some state-of-the-art therapies and state-of-the-art prevention. With regards to my disclosure, my full disclosure, I've advised and participated in a number of activities with companies. I don't receive any honoraria because I do a lot of public policy work. In specific cases, Montefiore has received payment for my time spent for a number of companies that deal with therapeutics in cervical cancer and diagnostics. Also, Montefiore has received grant funding for research-related costs of clinical trials that I've been the PI of from a number of companies as well. So I just want to set the stage a little bit. We have a kind of a limited amount of time. I promise I'll stay on task here. You may hold up the card anyways, but yeah, I'll stay on task. I'm going to talk a little bit about just the natural history, just to kind of set the stage for those of you that aren't aware of some of the issues when it comes to HPV. There is a lot out there. I'm going to discuss some of the current novel targeted therapies and their associated translational components in clinical development of cervical cancer and neoplasia. I don't have a lot of time. I'm going to focus on a couple of examples. One in particular, prediction of some biomarkers that we have for predicting disease that we are doing actively here at Einstein and Montefiore, and also the biospecimen acquisition that we have as a result of some of these clinical and translational activities, and talk about a specific HPV therapeutics queue that we have here. And I talk about queues, I could talk about a number of our gynecologic oncology queues that we have here for a number of our cancers. We have queues for first-line, second-line therapies for many cancers as well as for prevention. I'm going to focus on one queue where we've been really paving the way and paving the science with regards to the direction of how we should be performing these clinical trials and kind of the direction of how those therapeutics are developed. This is what I operate on a regular basis. This is a cervical cancer that is actually surgically amenable. A lot of cervical cancers are not surgically amenable because they've gotten outside of the cervix. This is, and for those patients, they have to undergo radiation therapy. And we have actually shown here, we're one of the first institutions that have actually combined chemotherapy with radiation therapy to show a kind of a synergistic effects. These were phase 2 trials that were done here at Montefiore in the early 1990s. And this has really now become the state of the science and actually the current standard of care when it comes to the treatment of locally advanced cervical cancer. This is as you can imagine, you got bladder up here, you got, rectum down here, you've got ureters and a number of other kind of vital organs in the surrounding tissues, and I can tell you this is a morbid procedure. This affects women in the prime of their reproductive lives, and most women that suffer from locally advanced cervical cancer have not approached menopause yet. This used to be the #1 cancer killer of women in this country, not so long ago, okay? With the advent of Pap tests and with the advent of regular use of Pap screening and widespread screening, we've shown this is an epidemiologist's dream. You have an intervention and we have a sharp decline in what was a very morbid disease. Yet we are kind of plateauing. We still have a tremendous amount of cervical cancer. Unfortunately, here in the Bronx, and it's not that we're not screening women in the Bronx, we're screening plenty of women. A lot of women come to us from the Bronx. I mean, a third of the Bronx community are new immigrants. They come to us having never been screened. We often get patients literally coming off the plane and coming into our ERs and clearly have seen a provider in some other country relatively recently, and we take care of them here at Montefiore and Einstein. That being said, while we have relatively low incidence rates because we have very decent screening and developed areas and more of the big areas that have national screening programs, cervical cancer is still the #1 cancer killer of women in most countries. It is the #1 cancer killer of women, particularly in those areas that don't have the appropriate screening. And then you have areas like China and Mexico where it is still the #1 cancer killer of women, but in cities they're starting to organize programs and they have very decent screening. We have done a lot here with therapeutics. I could talk for a while about the therapeutic wins that we had. I told you about our concomitant chemoradiotherapy as a win for locally advanced cervical cancer that has ultimately led to what is the standard of care in this country for the treatment of cervical cancer. But there's nothing that is really approached anywhere near, in terms of our therapeutic wins, in terms of the survival and the benefit of women than some of our prevention strategies and some of our leaps that we had with the prevention of some of these cancers. All this stuff kind of starts with this human papillomavirus, and many of you are familiar with human papillomavirus, but it is a double-stranded DNA virus. This is highly species-specific. There are bovine papillomaviruses. There are avian papillomaviruses. There are papillomaviruses that have existed in fossils that predate dinosaurs. This has been around for a long time. It knows how to survive, okay? In humans, there are more than 15 cancer-causing types, and the most common types that cause the largest burden of cancer are HPV types 16 and 18. Sequences, HPV DNA sequences, have been found to be integrated in more than 99% of cervical cancers. In fact, the association between HPV and cervical cancer is far higher than that between smoking and lung cancer. And unfortunately, this has been proven prospectively as well. It is the most common sexually transmitted infection, and I use sexually STI very specifically because disease related to this is extremely uncommon. The lifetime, I spend a lot of time in my clinics talking to my patients in the Montefiore clinics, that this is a ubiquitous virus. Everyone's got it. Everyone's been exposed to it. However, very few people will actually develop some sort of clinically relevant disease as related to it. I get a lot of people that come to me being like, I got HPV, I'm going to get cervical cancer. I'm like, well, the fact that you're here means that you have a better chance of winning the lottery than getting cervical cancer. The point prevalence rate of HPV infection at any given time, if I start testing women, is about 27%, with the peak incidence in the young age range. However, that is also the age range where most of them will regress their active HPV infections. Condoms, they're useful, They're at best maybe marginally effective, and there's a lot of social barriers that also limit the condom effectiveness, and many of you who do some of this prevention and STD prevention are very aware of this stuff. So, but even if patients develop a disease, a clinically relevant disease, and really at best, what, maybe 6–7% of Pap tests are abnormal, very few of the early abnormalities will actually progress, you know, maybe 11%. Most will regress, and even if they become higher grade abnormalities, you know, it's about a 50-50 shot that some of them will regress. Yet we don't have a lot of those predictive markers to know who is like that, you know, 1 in 10 that's going to progress, and who are, like, for patients that have high-grade precancerous lesions, which is the half that's going to progress and which is the half that's going to regress. So right now, what do? Well, we treat all of them, okay? We don't want any of them to progress. So most treatment for this is over-treatment. You know, when I see the paradigm of the progression to cervical cancer really focuses on persistence, okay? It's, you know, typically the patients that get high-grade disease are patients that have this long history of, you know, equivocal or early Pap tests. You know, they're SIN1, low grades, and then all of a sudden, boom, they get a high grade, okay, or even worse, okay? But, you know, and you know, I could talk about some vaccines, and we've been very active at Montefiore in the development of a lot of the currently now FDA-approved vaccines. We're one of the biggest sites on a number of trials, and we've led a lot of these trials. They are effective, but, you know, they're just really starting to get out there and starting to get used, and also they're only effective for preventing the types for which they're designed to prevent, which is 2 out of the 15. Okay, so we still have some more work to do, and certainly we are certainly in the heart of those prevention strategies. But when I see a patient with a persistent infection or SIN1, I don't know if that patient is a SIN1 that is, you know, destined to become cancer if I don't avert it, or if she's like that person that is really just a cytomorphologic manifestation of an acute HPV infection that's going to go away, which the majority of them do. And this is not an insignificant amount of women. This is about 2 to 4% of females at any given time in the United States and in most developed countries that are testing for this. All right. The current management is close observation, and for the OBs in the room, I saw Roger stand up earlier. You know, what do we do with these patients with a poor follow-up? You know, this is a disease that affects the young. The peak age prevalence is the early 20s of this kind of disease, and we all know that this is a time when there's a lot of geographic migration of these patients. They're going to school, they're working. We don't know if they're going to be back in 6 months, 12 months. So there is a lot of potential, and certainly there is a lot of overtreatment, okay? Also, there's some pathologic issues that make it, you know, kind of easy to kind of misclassify this. And also, you know, so there is really a need for some correlative markers to help minimize. You know, it would be nice to have some point-of-care testing to be able to say, you know, you're the one that's bad, and and for those that aren't bad, which is the majority of them, say, you know, this test gives me great confidence that, you know, things aren't going to get really much worse. There's also some potential for some therapeutics, which we have in development. There's been a number of tests that a lot of companies have taken up, and we've been working with some of these companies on some of these diagnostic tests, looking at specific typing to actually be able to predict outcomes, looking at some cytogenetic markers, as well as some what are essentially immunohistochemistry type of markers that may be able to give us a better, you know, idea of the, not necessarily the positive predictive value, but really the negative predictive value, which is what we're trying to shoot for. A positive test may not necessarily mean something, but we're really shooting for that negative test to give us greater comfort that we could observe them more safely without having to do some sort of over-treatment. What we've been doing here, and we were funded by the American Cancer Society to prospectively recruit patients with SIN1 and follow them forever, all right? And every 6 months, what we're doing with these patients is not only are we doing their biopsy for pathology, but we're also taking another biopsy of tissue that is adjacent to the pathologic biopsy, and also taking a biopsy in the same patient at the same sitting of what is colposcopically normal tissue. Okay, so in a lot of ways there's some tissue specificity, there's patient specificity, and we follow these patients prospectively every 6 months and do the same thing. We're also drawing blood markers. We're taking peripheral blood mononuclear cells and cryopreserving them so we could look at some of these systemic responses that these patients have in addition to their local responses, and we've been snap freezing it right in our clinics at Montefiore. And one thing, and this is what we were particularly funded to do, but we've been collecting a lot of tissues that we could do a lot of other things, and we've been actually working with other teams of basic scientists here at Montefiore to actually look and see what else can we do with some of these tissues, particularly with some of the immune aspects of this, what is essentially a virally mediated disease. But we've been looking at the epigenetics of things. We think that when we have this patient, where the patients are their own controls prospectively, by uniquely being able to follow those patients, any gene changes that will happen in the future are changes that are likely relevant to this process of malignant transformation. So we've been using the Illumina system. I've been working with Tom Belbin and Nicholas Schlecht, who's in Epi, and Tom Belbin, who's in the Department of Pathology. And we've been actually testing a lot of these tissues in patients that actually change during this time period. Most of these patients don't change. Most of these patients stay SIN1 forever. But those patients actually regress. Those patients that unfortunately progress during this time period, we could actually show these gene changes and compare it to the same patient 6 months ago. We've been finding some clustering patterns, and while we're in the middle of writing up one of our first manuscripts for what has been a very active recruitment process in Montefiore clinics, but we have identified some genes. So we've looked over 27,000 CPGs, and when compared to the initial lesions, follow-up at later time points in the same subjects, there were about 158 different genes out of those 27,000, with one gene that had a significant change across many of the patients in methylation. We're going to be presenting this stuff at a big conference soon, so I'll get into that eventually. And then compared to those patients who regressed, there were also 83 different genes with 3 genes that had significant differences. So again, we want to focus on the types of genes that could give us a little bit more of a sense of security. So how nice would it be to have be able to develop some rapid and predictive markers? And not only are we doing, the single platform of the CPG, but we're doing fresh tissue, we're snap freezing them so we could do RNA work, we do RT-PCR, and usually a secondary platform like methylite to actually see if it actually is true and if it actually is real. And we do that with the expertise that we have with our Einstein basic scientists. I want to talk a little bit, shift to another example. We do a very good job with treating cervical cancer. Even with radiation, death rates are pretty low. That being said, the therapies that we do, particularly for precancerous lesions, are stuff we've been doing for about 20 years. We haven't really made much of a change. We're doing what we call these kind of comb procedures, and you can see what we do, where we kind of remove these cells, the abnormal areas on the cervix. And you can see why they look like cones. But if you can imagine, you got a cervix that's about 3-4 centimeters long. It does weaken the cervix. And again, this is what we've been doing for 20 years. It's very effective at doing this. The peak age of the treatment of this disease is 25 in the United States. Okay, and most women are delaying their childbearing. Okay, and this is done about 500,000 times a year in the United States. Okay, so this is an extremely common procedure that's being done. Okay. There's been a number of relatively recent articles that are mostly meta-analysis, retrospective reviews. There has been a recent Cochrane database review that these procedures actually potentially do cause some element of preterm birth. Okay, that element, at the worst case scenario, is probably on the order of about 1 to 2%. Okay, and we tell all our patients that have a LEEP, you got about 1 to 2% chance of increasing your risk in the future of having preterm birth. And I wear my obstetrician hat when I say, I want to know that if I'm an obstetrician. I want to know if they've had one of these procedures because we may do a lot more surveillance on them. But when we think about 500,000 women per year are getting this treatment, even 1 to 2%, we're talking about 5,000, 10,000 women per year that ultimately potentially are at risk for preterm birth directly as a result of these procedures. So I think we can do better. In a lot of ways, surgery, as a surgeon, I could say that surgery doesn't necessarily overcome the biology of this disease. The biology of this disease is this a virally mediated disease. So we've been looking very much at our kind of the immune responses of this disease, and our overall kind of 30,000-foot view hypothesis of this is that in those patients that actually have the adequate immune response, they're the ones that are most apt to have HPV clearance. But those that have persistence are the ones that have very little, no immune response or inadequate immune responses. I mean, we have, certainly a tremendous amount of literature in our immunocompromised patients with regards to this relationship. When those that don't have any immune response, they have persistence to their HPV infection, and they're certainly more apt to have recurrence and progression of their HPV-associated diseases. We know that this disease replicates without inducing any cell death, and there's no systemic there's no systemic, entity to this disease. It's not like hepatitis where there's like some sort of prodrome or systemic entity. Patients don't have any symptoms from this disease. This HPV replication occurs also in an immunologically isolated site. It comes in through microabrasions above the stromal membrane. It infects those basal cell layers, and it replicates within the cell until apoptosis happens, way above and way outside of the normal immune defenses and outside of the immunosurveillance of the host. HPV also negatively impacts on the appropriate cell-mediated immune responses directly, okay? And it downregulates some of the kind of keys to the innate immune response through the toll-like receptors. We've also identified that there are some polymorphisms in the tumors, in the transporters, in the genes of the transporters associated with antigen presenting that could potentially increase or actually decrease the host immune responses. And this is based on some prospectively collected samples that we've had in our Montefiore patients. So our overall hypothesis is that in patients that have ineffective cell-mediated immune responses, they're the ones that are more likely to have persistence of their disease and then apt to progress. In those patients that have decent cell-mediated immune responses, which is the majority of women, they regress. And we think that we could kind of drive that regression by improving their cell-mediated immune responses. Also in parallel, and I'm going to talk about why it's important to talk about these things in parallel, but we have some pretty poor reproducibility in some ex vivo assays. You think about it, the stuff that happens in the cervical vaginal tract, how can we really detect it in the peripheral blood, okay? And a lot of times it doesn't really correlate. We get responses all over the place, and patients aren't mice. There's a lot of variability in the responses. Also, oncogenic HPV can skew those T cell responses to favor survival. This is one of its mechanisms of why it's been around for so long. And again, we've established this biologic plausibility in our immunocompromised patients. So these immunotherapies have been really in active cues in solid tumors, and a number of them, not just in cervical disease, but in melanoma, colon cancer, and breast cancer. A bunch of you are working in some of these solid diseases. One of my roles, I co-chair the vaccine committee of one of the largest cooperative groups in the country, and as we're working with the FDA to talk about how do we get some early markers that will ultimately correlate with clinical responses. This is the draft guidance that we're working with the FDA. This is almost going to be out, and this is what's ultimately going to be the final wording. But as part of the development, multiple monitoring assays may be needed to identify the component immune responses. And when the FDA says we recommend that, if possible, 2 immunologic assays be used to monitor the immunologically mediated anti-tumor response, well, if they recommend that, that means you got to do it. Okay, so we've been in the heart of developing some of these assays through our Einstein Montefiore clinical trials. This is kind of novel science for oncologists. We're typically used to our cytotoxics or our targeted therapies and looking at trying to personalize our targeted therapies to get better responses in patients. There is a lot of unique developments in the boilerplate protocols that we have for this type of cue, and I'm going to talk briefly about that. The biomarkers are really novel. They're not developed, but we are, I think, paving the way in cervical disease, and it's certainly an evolving scientific discipline. I just want to give an example of where things are a little bit unique in terms of these types of immuno-oncology. So this is our conventional KM survival design assumptions. There's usually no events that occur, and at some point in time there is some splitting of the KM lines. Proportional hazard models apply to the standard KM curves that we have, and usually we're powering these types of things for progression-free survival. This is a newly FDA-approved prostate cancer vaccine. I'm sure some of you heard about this. This kind of came under a little bit of scrutiny because really the lines kind of separated where there was maybe about a 4-month, there's a p-value, there's about a 4-month progression-free survival improvement with this vaccine over standard of care. And that being said, it costs about $90,000. So I could talk about the pharmacoeconomics of those 4 months of added life. But what I think you guys can see even in the back of the room is the separation of the curves didn't happen right away. There was kind of this delay in the separation of curves. And what we're realizing with a lot of these immuno-oncology and these immunotherapeutics is they may not have a response right away, but those responses seem to happen overall later on. So we've really had to throw out the typical statistical assumptions that we normally do with our standard cytotoxics and kind of power things to overall survival, for instance, and power things to where we have more, where we basically have to follow patients for life, as opposed to just in those 2-year periods of time, because we may be missing the time when the curves separate and throwing out the baby with the bathwater. So this has been kind of our active cue in precancerous lesions, and I am going to touch base about how we've been developing and paving some of these immune monitoring assays here at Montefiore and Einstein. I'm going to talk about this trial that we did back in between 2003 and 2005. This was an NCI-sponsored trial using this peptide-based vaccine, which includes an immunostimulatory, kind of heat shock protein. This is in and of itself, for those of you who are in the TB world, this is in and of itself a big immunostimulant. And this is a peptide vaccine that's tagged to a full-length HPV 16E7. There was some phase 2 data to suggest some activity in anal intraepithelial neoplasia as well as RRP, although the endpoints of the RRP trials was time to next surgery, so I don't know how you could interpret that. But we had done a trial in carcinoma in situ of the cervix with this NCI-sponsored, through this NCI-sponsored trial through our New York Cancer Consortium, which is a Montefiore-based program consortium. So we vaccinate patients monthly. So, instead, patients come in with high-grade disease, they would need a LEAP now, but instead of doing the LEAP now, we delay the LEAP 6 months. And during that time, we give them this vaccine. We did a number of blood draws for which we've developed some assays as a result of that. We did HPV typing to actually see if this vaccine had any relationship with the typing. We also looked at clinical responses, particularly with colposcopy. This is a low-resolution view, but you could imagine these patient pre-vaccination had a disease, and if they had a response, we didn't really see anything colposcopically. But if they still had clinical evidence of the disease, even microscopically, they weren't a complete pathologic response, obviously. So we had a clinical response in the vast majority of patients. We had published this, and this actually then eventually got developed by a company which ran into money problems, but I'm not going to get into that. But, this is typical for some of the clinical trials for those of you who deal with this kind of stuff. But, the majority of patients had a response to this trial. And there was no really significant, tweaks of demographic or behavioral. But, the N was, 70, so it's hard to say if we were underpowered to look for these associations. And it was a very well-tolerated therapeutic in what it was a young, healthy population. One of the postdocs in Robbie's lab had taken some of our serum, and he was working on some competitive Luminix-based peptide assays. And he took some of the serum that we had in these patients, and we blinded looked at this E7 antibody serologic response. And yes, there's some wide confidence intervals, but there was a significant difference in patients that had a complete response with what is a high throughput, relatively cheap assay. And again, this couldn't have been done without really having that stuff available here, and we developed it at the Einstein labs. And this is something that we are also using in other E7-related protocol designs in future trials. So, in summary, I'm wondering, as a surgeon, should we be operating on a virally mediated cancer? I think that that we have some room to saying that maybe surgery is not the end all be all of this type of treatment. There are rapidly advancing vaccine and immuno-oncology technologies that are giving us access to many of these what are pretty cool novel therapeutics. But in parallel, the immune correlates of response need a lot of development, and I think that that's something we're uniquely poised to do. At Einstein and Montefiore, and we've been doing this. And there is certainly the potential for a major decrease in the health burden and the morbidity of the treatments that we have in what happens in a very young population. So I couldn't do any of this without any of my collaborators across a number of different departments at Einstein and at Montefiore, and our funding sources, which I've named here. And most importantly, thanks to our patients in the Bronx, who we like to think we're providing state-of-the-art therapies to. Thank you.
Thanks, Mark. That was marvelous. And he actually left us a couple of minutes for questions. And one of the first questions, I guess, is how do you do all of this, Mark, and see patients and have, how many kids is it now?
3. No, I think all of us that do this know this is a lot of effort, and we have a lot of help, and we have a lot of collaborators, and it's a matter of trying to be as efficient and OCD as possible and trying to stay on top of it. But most importantly, also, not throwing out any of the good ideas. I think all of us that do clinical research, we want to kind of develop a lot of these ideas. I could tell you for every one of these, our successful projects, we probably had 4 or 5 duds. So you never know.
I think the other point I think that's really interesting is the work with the FDA, and some of you will be hearing shortly about activities that have been really spurred by this historical separation of various government functions that relate to clinical research. And NIH is actively working through its CTSA linkages, but also very independently of those with embedding an FDA-NIH partnership. And I think cancer has led the way in many ways to developing the kinds of platforms where you can develop these studies and then deploy them in a much more intelligent kind of way rather than waiting for happenstance. So.
No, but and I also think that you know, the FDA has really opened up its doors to getting guidance from the people that are actually doing these things, and I think it's been very helpful because we hold, you know, the feet to the fire to, you know, the companies that are trying to develop these because we want to get the best science that's out there, even if it's a negative trial, and if we believe in the p-value, most of them are going to be negative, but also so that we could actually get some early markers of these responses. And I think, you know, they open it up to some of the investigators pretty early before it becomes finalized, and I think that makes it very open and transparent and helpful process.
My question definitely digresses a little bit from the pure basic part of it, but we did have a good laugh about the whole thing, eat right, you won't get cholera. The problem is eventually one has to recruit the patient on board in order to obtain the good results. It's because we were able to really instill into the patients that mammograms frequently as well as pap smears do protect from cancer, breast cancer, cervical cancer, that we are obtaining these good results. When it comes to HPV, I've probably seen 1 or 2 patients who have ever mentioned the word Gardasil, for example, which is one of the HPV vaccines. How do you see us reaching the point where we are actually teaching and really instilling into the patients the importance of HPV? And at this point, what are the arguments or points that we can tell the patient in order to sensitize them more about HPV?
Excellent question. We spend a lot of time really educating our patients. You know, our thinking with a lot of these trials, when we're talking to them about these trials, we have the same kind of education that we give all of them. So our hopes are, even if they don't go on the trials, we make them better patients in the future and get them educated about that. You know, one of my other hats that where I do a lot of advocacy work out there with regards to trying to overcome barriers of screening for cervical cancer and cervical disease. And, you know, there is a tremendous amount of, it's complicated. When it comes to these barriers. And it's not just, you know, everyone thinks it's really easy, access, not enough insurance, or not, you know, it's not really like that. There's also patient-based, you know, barriers as well. The patients, you know, they don't understand the need potentially for some of this. There's like a fatalistic attitude in some of our ethnic minorities when it comes to cancer, like, oh, if God wants me, he'll take me, that kind of stuff. You know, and trying to educate them, saying we can actually do something about it. We could pick this up long before it becomes cancer. So, and I think not everything that works in every community is applicable to other communities. You know, what's unique to our Bronx patients may not really function very well in other types of communities. I could tell you from experience that most certainly it doesn't. Our Bronx patients are pretty unique. So I think you know, as the prior speaker, who's a tough act to follow, had talked to us about, you know, it's you know, gathering that information from the patients and trying to figure out where those gaps are of knowledge, and then trying to work to educate to overcome some of those gaps with relatively simplistic things. Keep, paying close attention to the cultural differences with our patients and some of the illiteracy issues that we have with our patients, and trying to overcome that with more education. And, you know, I think that's what all the clinicians at Montefiore try to do. At some degrees, we are more successful than with some things than others.
Thanks, Mark. Thank you.